Hi, my name is Dinaris Carl, and I'm doing this video about interdisciplinary collaboration for my assessment of collaboration and leadership reflection for my class Nurse FPX 4010 at Capella. In this video about interdisciplinary collaboration, we'll be knowing about an experience that happened in a hospital setting, what went well, what did not go so well, what interdisciplinary collaboration was needed, and what could be better. We're also going to identify how peer collaboration can result in an efficient management of human and financial resources. We're going to cite some authors. We're going to identify best practices, leadership strategies that would improve an interdisciplinary team's ability to achieve its goal, and also how interdisciplinary collaboration can be a key on work together. And we're also going to cite others. Basuri defines collaboration in healthcare as the capability of every healthcare professional to effectively embrace complementary roles within a team, work cooperatively, ensure the responsibilities for a problem solving, and make decisions needed to formulate and carry out plans for patient care. At the end of the day, what we do in a hospital setting is to work to provide a better outcome for the patient, advocate for the patient, and make the patient to feel better. A situation happened to me in my work settings. I work in a telemetry unit with a cardiac monitor unit. And I had a patient, an admission of a patient that came in with a history of bradycardia, hypertension. The patient was also had a history of hyperlipidemia. After I finished my admissions documentation, I assess the patient, make sure everything is okay with the patient. The patient came in with also the chief complaint was a mild confusion and weakness. So I assess the patient, I provide the patient everything that he needs, assess his fall risk and all. I saw that the patient has some medication prescribed. And within the prescribed medication, the patient had a ACE inhibitor and a beta blocker. And also a patient for his hyperlipidemia and a statin. When I had explained the medications to the patient refused the beta blocker and wanted to take the ACE inhibitor. He told me that he was taking the beta blocker, but then he stopped. When I proceed to administer the medication to the patient, once 11 o'clock vitals were due, the PCT went and took his vitals, and then everything in his vital was fine. At this point, no complaints from the patient were made. The patient called the nurse station around 1 a.m. and his complaint was that he was developing hives and he has an itching. At that point, I recognized that it could be an allergic reaction to the ACE inhibitor. He was breaking and he was developed like this red spots in his body. I contact the provider. I provide the provider and his bar with the situation, background, the assessment I did with the patient. And I asked if the patient can have an anti-allergic. At that point, I didn't have no response from the provider for 20 minutes. That's when peer collaboration came into play right there at the moment. Me as a nurse that advocate for my patients, I didn't feel happy with that silence from the provider, and I contact another provider. The other provider asked me about what was the patient history, what the patient was there, what medications I give to the patient, and I provide her that information that I already did in the previous message to the previous provider. And she provided us 6.25 milligrams of Benadryl for the patient to start with due to the patient's age. The patient was 79 years old. I provide the medication. Once I provide the medication, then I got a message from the other doctor that put an order for Benadryl 25 milligrams, but I already prescribed 6.25. And the patient was responding good to that medication. Highs were decreasing, issue was decreasing, and patient was getting better. So what went well right here was, I believe, was me having the communication to another provider. So I went more than just that provider, and I tried to advocate for my patient and get a solution for his issue at the moment. it did not go well that the provider just make a silence when he could be asking me questions and I could be replying to him right away and explain him, giving details of the patient's situation so we can have a better outcome for the patient. It could be better that happened at that moment. It didn't, but actually the patient had a good outcome. The patient could develop a rash and could break his skin. His skin was very fragile. Patient was also bruising easily. He could also break his skin, bleed out of it, and it could be a more complication, and that will result in better, more costs for the hospital and for the patient. There is collaboration among healthcare teams, unfortunately, and some of these poor collaborations can deal to some consequence, as Beatty explained in his paper. Some of the consequence will be like medications confusion. The lack of collaboration can result in conflicting medication orders. The patient might needed the 25 milligrams, but actually the patient was good with 6.25, and it helped him. Then also, there could be medications missed. It could be that previously the patient had a reaction to the ACE inhibitor. And since it was not noticed on his patient allergies and he was not like a good collaboration in his previous care, that probably could have happened that the patient developed the rash. Bates also explained that polypharmacy could be a risk as well for the patient. We could be multiple medications could be an interaction for adverse effects. This can lead to the patient, the length of the patient, the state of the patient can be longer, because we have to keep treating other complications. And also it could be patient dissatisfaction that the patient will experience frustration due to inconsistent information or developing something else at the hospital. All of this is explained by Bates in his paper, Incidence of Adverse Drugs and Events and Potential Adverse Drug Events, Implications for Prevention. So at the end of the day, what we do here is to prevent patients to get complicated and also make the patient to be better. Working together, according to Collins, there is this model achieves like positive outcomes and not appear just to be for the patients. It also can be a good perception for the clinicians. That makes them feel better of the job. Always like getting a patient to feel better, accomplish that the patient it's getting better. It also will be a good satisfaction for the providers, the healthcare team. And if the effective leadership strategies on an interdisciplinary collaboration, it will be like a clear communication, shared vision of emerge as essential components. Having leaders that promote open dialogue and articulating a common purpose that align with each member's expertise. So a doctor might know better about what to prescribe to a patient and what a patient, but the nurses can make recommendations according to their expertises as well. Additional transformative leadership characterized by adaptability and proactive problem solving. It found to empower teams to navigate challenges efficiently. So we both, everybody on a intercollaboration situation can provide something good to a patient situation so the patients can get a better outcome. And our performance and our accomplishments will be way better. This is explained by C. Smith and Johnson in their papers. Citations are already has been updated for this video. I hope you guys enjoy it and get something off of it. This was my paper, my presentation, my video presentation for my intercollaboration.